thank you, Constantine. Certainly it's a pleasure and an honor to be here today. And you've heard some fantastic talks and a lot of information, and probably like most of us, probably have more questions than you have answers. And I don't propose to give you all the answers, but hopefully I can fill in some of the defects or the gaps that we have in some of our knowledge base. And as you've heard from everybody today, this is a complex problem. And it's complex for lots of reasons, and a lot of you know those reasons. But I think as we do more and more research and do more and more studies, some of these things will be resolved. So my job today is to give you an overview on outcomes and long-term outcomes. And there really isn't very much on long-term outcomes. And I'm going to share some light on outcomes with respect to age, kids with hypermobile scenarios, long-term settings with open versus closed decompression. So we're trying to answer some of these more controversial areas when it comes to Chiari. Now, a lot of it's going to be pediatric, but at the end of the day, although kids are different than adults, and I'll share with you why, at the end of the day, there's a lot of features in this that apply to the adult population as well. We have no financial conflicts of interest, and we are grateful in the past for support we've received from ASAP for some of our research. Now, it's fair to say there really is a paucity of long-term data on outcomes from surgical repair for Chiari malformations, both in the pediatric world and the adult world. And even today, there's still controversy, long-term controversy over what's the right way of doing it and how do these patients actually do. And when you look at a lot of the data, it's 2-3 years, that may or may not tell the whole story. And our goal was to look at our kids in the last 24 years in Washington, D.C. that had Chiari decompressions and to see how they did with a minimum of 5 years of follow-up. And that's problematic because a lot of patients don't want to come back after a period of time or they move and everything else. We want to look at our long-term outcomes relative to the type of surgery that was done and relative to factors that may relate to reasons for failure. And we'll talk about that a little bit. So the first question, and again, you put up what is a Chiari malformation in front of this group of group of people in the audience. And I think the key thing you have to remember, is this an X-ray finding? Is it a clinical condition? And I think that's part of the battle. We throw this name around all the time. As you already know, it's not the same thing. Everybody in this room has a different problem and a different story. Everybody has their own textbook. And is it a different disease for different ages? Are kids different than the adults? The answer is yes, and I'll show you why in a second. And ultimately, is it driven by the etiology? You're looking at an X-ray with low cerebellar tonsils. What's making the tonsils low? You have to go back to the basis. What's causing the X-ray picture? Everybody knows the definition of Chiari malformation, and as you know, there's 1.5s and there's zeros. I'm sure we'll have a negative number at some point in time, but that's probably more reflective that this is a different condition with different etiologies for different people. So remember, it's an X-ray finding, and different etiologies may present with the exact same or very similar clinical condition. And you have to look at this and look at outcome as well. If you're looking at different causes for cerebellar tonsillar herniation, this might be different outcomes depending upon what the type of problem is. As we all know, you all in here, a lot of you folks are intimately involved with Chiari's. Their presentation is very variable, and it is age dependent. I put fill in the blank on the bottom too because it's all over the place, and the presentation is also extremely variable. At the end of the day, you have to figure out what's related to the X-ray finding and what isn't. You have to go back to the probable etiology or the cause for the X-ray finding to get a meaningful way of fixing this. And one operation or one therapeutic approach does not solve all the problems because they're all different. So as a neurosurgeon, I try to keep things simple. I'm a real keep it simple kind of guy. And so while this may be very superficial, I kind of look at Chiari etiology as being fourfold. You either have a small posterior fossa volume. We've published on this. We've demonstrated that younger kids very often, and even some older kids, can have small posterior fossa volumes. It's just like the toothpaste. It gets squeezed. The tonsils get squeezed out of the head. A lot of our patients have an outflow of CSF, outflow obstruction. You've heard some great talks already, and John talked a lot about CSF flow dynamics. Well, if you have an obstruction, spinal fluid ends up going down the central canal. You end up getting a syrinx. And this is about 10 to 15% of our pediatric patients, there's something from above that's pushing the brain and in particular the tonsils below. You heard earlier about idiopathic intracranial hypertension or what's known as pseudotumor. If there's pressure above, we've seen it. They come in with headaches, they have low tonsils, you put them on Diamox, the headaches get better, the papilledema get better, and shockingly the tonsils have risen back up. You have kids with pansynostosis. They have craniofacial issues. Their brain is growing faster than the skull. They have intracranial hypertension. They have pressure. Shockingly, the tonsils are low. The problem is on the top part of the head, not on the bottom part of the head. And then, of course, they're the most vexing patients are the ones with the craniocervical instability, the kids that have the hypermobility or the EDS pictures you heard talk earlier about that. Those kids, the problem is more than just the tonsils. It's obviously a structural problem, the craniocervical junction. So in the last 24 years, we've had a little over 1,100 patients we've followed for Chiari. And as you can see, it's almost equal between the boys and the girls. And the average age of diagnosis is a little over 8.5 years. And at the end of the day, we ended up operating on roughly 29% of these patients. We do have a large number of incidental kids that come in. They've had an MRI for a variety of reasons, seizure workup, trauma, whatnot. They don't all get operated on, but we do have a lot of these patients to follow. And from a surgical standpoint, roughly 57% of these patients go on to require surgery because of progressive disease. About half of them present with a syrinx. And what's interesting is that almost 7% over time develop a syrinx. And they didn't have it beforehand, but we were watching because it was an incidental finding and so forth. And roughly 20% of these patients have scoliosis. For our institution, the indications for surgery, and again, you have to go back to the base reasons. Why are we operating this patient? Try to figure out why and how they do. Intractable occipital Chiari-like pain. Intractable means you can't go to school, you can't play sports, you can't go to work, is an indication. Anybody with a neurological change or finding is an indication. And certainly Syringomyelia, not just a prominent central canal. And like Jerry said earlier, with a lot of kids that have generous canals, maybe it's a syrinx, maybe it's almost a syrinx, and then we'll watch them. And sometimes they do better and sometimes they don't. And ultimately, in this setting, the definitive treatment is surgical, and your goal is to restore CSF, normal CSF flow patterns, while at the same time minimizing scar formation, which you just heard about from John. So when you're talking about surgery, you're looking at opening up the dura, duroplasty, maybe a stent, versus closed, you're just removing bone and maybe the outer leaf of the dura. Very different operations. We'll talk about that more in a second. We use intraoperative ultrasound, so does that help you? Does it help define how far do you need to go? What do you do with the tonsils? We'll talk about that a little bit. And whether the patient needs to be fused or what kind of duroplasty. What's changed for me, and I've been at the hospital for 25 years, is we've kind of tailored or changed our approach to repairing Chiari malformations, but what we think is the presumed or probable etiology for the low tonsils. And if we have very young patients that have a tight or small posterior fossa, we'll just keep it simple. We'll do a bone operation. We may remove the outer layer of the dura. We'll use the ultrasound to define if we made more space. And those patients do very well, and I'll show you how they do in a second. For the patients that have a neurological deficit, you really don't want to sit on that, or with a large holocord, giant spinal cord syrinx, we know that that's not going to work. We've changed our direction. They need the real operation, so to speak. They need to have an open operation with the duroplasty. And then the kids that have pseudotumor, the kids that have occult hydrocephalus, or the kids that have craniosynostosis, where there's pressure from above, I don't think the answer is back here. You're going to get yourself in trouble. The answer is up at the top part of the head. And then when you look back at our numbers, 40% of our patients have had bone only, roughly 60% have undergone a duroplasty, and roughly 15% of our patients, and you can see there that stent on the right, I don't know if this, I'm not even going to try pointing this thing, but you can see on the far right there, we'll put a stent in for those patients. This is an interesting example. This is just kind of shows you the gamut of what we have done. This is a long time ago. We would do this child differently. 12-year-old boy comes in with scoliosis, healthy, no symptoms, his exam's normal. And his MRI scan shows a picture you've seen today a million times. He's got a Chiari malformation. He has a pretty extensive syrinx. Family is extremely conservative. We said, we've got nothing to lose. We'll just do the bone. We did the bone work. And not surprisingly today, and to some of you in the audience, this syrinx hasn't gone away even up to 2 years later. Scoliosis is getting worse. He's still asymptomatic, but now we're worried about the scoliosis, where we're going, and the family consented to doing an open operation, at which time he had significant adhesions. You can see there's no wonder the spinal fluid can't circulate, and we ended up putting in a stent, and lo and behold, there he is afterwards with the syrinx going away and his scoliosis improving. So as you already know, we talked about recurrence. We'll talk about that in a second. There's a whole range of options here, and I think we try to start simple, but at the end of the day, you want to do stuff that works. So how do these patients actually do? And the outcome is going to vary because not everybody with a Chiari is the same. And it's tough when you look at the literature. How do you define a failure? And how do you define a success? And what about the age of the patient? Do they have comorbidities such as a hypermobility or an EDS picture? How long have you followed up the patient? I mean, long-term follow-up is obviously better than short-term follow-up. Are you looking at subjective factors, pain versus the size of the syrinx? Are you looking at a prospective versus retrospective study? They do matter. And at the end of the day, what kind of approach was done? Was it done for the right indication, open, closed, and what was done to the tonsils and so forth? So quickly, for some brief literature review, this is Clay Clam's study, 371 patients. In the end, 82% of the patients are better by 3 months. The morbidity was low at 2%, but there is mortality. It's not a completely benign procedure. And the recurrence rate of 7% at 5 years and 8.7% at 10 years. And this is a study from Jerry Oakes. This is kind of the standard, at least in the peds world. 500 kids were done. And as you can see, 85% were better. 3% went back for another operation. And their morbidity, their complication rate was quite low at 2.4%. So the outcomes, you look at outcomes, you have to say, okay, what are we looking at and what are we defining? They're going to be dependent upon the age of the patient. They will be dependent upon comorbidities the patient may have. They'll be dependent upon the surgical indications. Why was the operation done? Was it done for pain? Was it done for the syrinx? Was it done for a neurological finding? We'll share some data with you on that, as well as the surgical approach. So are kids different than adults? Do they do better than the adults? The answer is they do, and I'll share with you why in a second. And then the question is this: is it a different condition for kids? Is it just an early stage of adult Chiari? Where does it follow into this thing? And again, not a lot of studies out there, but this is done in Memphis and Rick Boop's group. The kids statistically did better than the adults. And when we looked at this, you don't have to look at this slide in any detail, but we noted as the kids went from early ages, as Jerry said earlier, the little kids, 6, 5 years or younger, the kids that were 12, 13 years old, the preteens, and then obviously the teenagers, they did present differently, and they did behave differently, and they did do differently as far as outcomes. And again, on this slide, this is just to point out that younger kids presented more often with brainstem findings. As you get older, not surprising, the degree of tonsillar herniation, the degree of Syringomyelia, as well as scoliosis also increased with age. It would imply that perhaps it's a progressive process, but certainly different. Now, this is an interesting study. It's just been submitted. Hopefully, it will be published in the next few months. This is a study that came from a cooperative arrangement here with the folks at Drexel. Vez earlier was involved with this. John Heiss was involved with this in Washington. And we had 5 adult centers and our Center for Peds looking at how do the patients present and how do they do. And it's really the largest study of its kind with some meaningful numbers and so forth. And I'm going to give you a sneak preview on what the results are before you see it in publication. And as you can see here, we had a decent representation of the adult patients from the Georgetown, GW, NIH, Drexel, and our Institution for Children's. And what was interesting was in the adult patients, 87% or 86% were women. And in the kids, you can see significantly different at 5.75%. So clearly something's dramatically different between the adults and the kids. And the adults presented more often with headaches, bulbar symptoms, ocular symptoms versus the kids. On the other hand, the kids did better when it was relative to what was the indication. If they were having pain or the size of the syrinx and so forth, the kids did statistically better. And again, when we look at this, the kids were more at risk for having Syringomyelia. And at the end of the day, the kids seemed to do better as far as the improvement in their symptoms, but there was no difference in outcome for the syrinx between the adult and the kids. There was no difference in scoliosis, repeat surgery, or the complication rate between those 2 different cohorts. So you look at this, you realize these are different patients, and it probably reflects it's a different process why the cerebellar tonsils are lower in the adults than they are in the kids. What about hypermobility? What about EDS? And, I've gotten away from the EDS. I know it exists. It's just hard to define. It's hard to know what that means. I think hypermobility in our book, these kids are different. They are very flexible and they have a lot of other issues. And does this play a role in the outcome? The answer is most likely. And so, I always have to try to figure out what's the chicken or the egg, what's driving the symptoms. Is it the Chiari? Is it the low tonsils? Or is it part of their multi-systemic type of issues? And you heard earlier is pseudotumor, the 800-pound gorilla. What's hiding or lurking behind these patients? And is that contributing to the headaches and neck pain and so forth? And again, most of you understand what Ehlers-Danlos and hypermobility is all about. But you need to remember, it's not just Chiari's, it's not just hypermobility, but these folks have dysautonomias, these patients have autoimmune issues. This is a multi-systemic type of problem. And again, you all know this. What's often amazing to me, and I get a lot of these patients, is the symptoms they have are often way out of proportion from what they actually looks like. And that doesn't mean they're not having the symptoms. It's just you're sitting there saying, well, how much of this has been driven by the Ehlers-Danlos picture versus how much is being driven by the Chiari? And that is key, and I think you've all seen these pictures. We wanted to look at these kids and say, are they any different than the other kids? And so everybody that comes in for a Chiari evaluation gets a Beighton score. And so over 16 years, we found 39 patients who were clearly hypermobile. We compared the 248 patients at the same time to see if they were any different. Again, interestingly, most of the hypermobile patients were girls, were young ladies. As you can see down there, 87%, whatever that number is. But at the end of the day, if you operated for the right indications between the Chiari patients with hypermobility and those without, the outcomes were the same. And the surgical approaches were the same, the demographics were the same, and the outcomes, whether it was headache, syringomyelia, or a neurological deficit, statistically were the same. Now, that's not saying if you operated just for a headache that had nothing to do with the Chiari malformation, you'd have the same outcome. But the key was to figure out what was the forest and what was the trees. So then what about outcomes for the surgical approach? To open the dura or not to open the dura. And again, there's a lot of issues here. You need to look at the etiology or the presumed reason why those tonsils are low. And then we wanted to look at how do the patients do with respect to the headache, with respect to the neurological deficits, and with respect to the syrinx. Lots of papers out there. I'm not going to bore you with all the results. The bottom line is if you do the bone only, shorter, less morbidity, less complications, but more returns to the OR, more recurrences, and less successful when it comes to a syrinx. And again, this is a bunch of papers saying the same thing. For the sake of time, I'll move on until we get to stuff that's more recent. And this is actually something that just came out from the Park-Reeves study, and I think it's worth taking a couple of seconds on this. This is a group of neurosurgeons that are involved. I have to go back. It's 65 centers. So this is a wide spectrum. It's prospective data. A number of the docs in this room are involved with this. And what they wanted to look at outcomes for bone only versus the duroplasty with at least a 1-year follow-up. 692 patients. Interestingly, only 17% had the bone only. And the mean age of surgery was close to 10 years. And they had a little over 2.5-year follow-up. At the end of the day, and this seems to be more and more data supporting this, the patients got the bone only, shorter OR time, less blood loss, out of the hospital faster, 14% 6-month post-op complication rate, 18% revisions. The patients that had the duroplasty, the bigger operation, 0.7% intraoperative complications. You are opening the dura, you are looking at places that you're not supposed to be, so it's not without some risk. 24% 6-month complication rate, but only 8% revisions. Higher complication rate, lower revisions. So in the end of the day, this paper reported no difference in the neurological changes. So patients presented with neurological findings were the same between both approaches. Patients that had the duroplasty seemed to do better when it came to headaches and back pain. And at the end of the day, the greatest reduction in syrinx was seen with the duroplasty and so forth. So were there any long-term differences at our institution between open and closed? And this is a paper we published just in the last year. And again, looking at a minimum of 5-year follow-up. We really wanted to have a lot of time here. And it's interesting to look at that. We had a lot of kids the first year. We still had a fair amount of kids the second year. And by the 5th year, we were down to 60 patients. 42% had bone only, 58% had duroplasty. And again, you can see the failure rate for the bone only was 20% out of that large cohort. It was only 2.9% for the folks that had the duroplasty. Obviously, it's statistically different, and I'll share with you why. Complication rate, not surprisingly, was a lot less at 4% for the bone only versus 17% for the duroplasty. And again, when they looked at the page, presentation was very similar between both cohorts. There were more patients presenting with neurological symptoms that got the duroplasty because we didn't want to sit on it. And at the end of the day, as far as outcomes, you can see that the only thing that was statistically different was that the patients had the duroplasty had a better outcome with for the syrinx size. And again, same thing here. Hang on. So we looked at headaches, same, whether it was the bone only or the duroplasty. And over time, it stayed the same. When we looked at neurological symptoms, for the most part, the same. And when we looked at syrinxes, clearly the duroplasty is better, again, over time, at least over a 5-year time frame. When we look back at the reasons for the patients that failed, we noted that the kids that had the whole accord syrinx who were getting the bone only didn't do very well. And so when we stopped doing bone only for just the kids with the whole accord syrinxes, our failure rate dropped considerably. But we realized, and that's why at this point our redo rate is actually about 5%, because we're no longer offering the simpler, smaller, safer operation because it just doesn't work. And so we've had a bit of a philosophical shift in that. And again, the complication rate, 17% versus 4%, it's a big difference. So if you can do an operation that's as effective as the duroplasty with a lot less complications, it's certainly the way to go. So very briefly, what about failures? I got, I think, 10 minutes left to turn to the sign here. Well, what do we do with failures? Well, how do you define a failure? It is an issue that not enough time's gone by. Is it a subjective failure versus an objective failure? How long are you watching the patient? And of course, at the end of the day, what do you do to fix that? And the general failure rate, if you look at the literatures out there, is about 10%. Some places a little less, some places a little bit more, but ballpark figure of 10% if you look at the large series. So if the patient isn't getting better, is it because there's not been enough time? And this is an interesting paper that came out of New York where Rich Anderson and the rest of the guys saw that it sometimes takes 2.5 years to see a reduction in the size of the syrinx. So if the patient is stable, they're not deteriorating neurologically, you're not in any rush to make the syrinx smaller. Get to 2 years, nothing's changing, well, you may want to start thinking about a plan B. Is there comorbidity? Do they have other things going on? And so we mentioned earlier hydrocephalus. This is 6 centers around the world looking at patients that had no obvious hydrocephalus, they had normal-sized ventricles, and 5% of these patients went on to develop hydrocephalus after the fact. We're part of the study. I was shocked when we actually went back and found time we had 5% of our Chiari patients ended up getting a shunt at some point in time when they didn't come in with what we thought was hydrocephalus. And then, of course, there's the kids that have the hypermobility syndrome, and that makes it much more challenging. Did you do the right operation for the right reasons? So when you look at this, was the decompression adequate when you're looking at reasons why it failed? And the little kids, less than 5, the bone will regrow sometimes. So it may look great for a year, and then the kids are back 3 years later with the same problems. You have to look at that. There are sometimes kids that have too much bone removed. They get what's called cerebellitosis. The brain is actually hanging low, and they have their own set of symptoms. Is the syrinx still there because there may be hydrocephalus that didn't appreciate, or idiopathic intracranial hypertension? And at the end of the day, maybe you never got the CSF outflow at the foramen magendia open. You thought you did, or maybe there's more scarring in there. But ultimately, you've got to go back to the beginning and saying, what was causing the cerebellar tonsillar herniation? So if you have failure, you start at the beginning. You go back to the beginning, you start over and say, okay, what's going on? Why does this actually look the way it is? And other factors. And then you repeat your MRI and you look at CSF flow studies. Well, they're not always that. You wish they were more objective. They can be very helpful in telling you how much flow, does the flow look good or not. And as you've heard earlier, you do need to make sure there is an instability. Some of these patients they're less stable than you think they are, so flexion extension films can be very helpful. And has there been enough time? And ultimately go back, was the right operation done for the right reasons? It was interesting, years ago, our failure rate, as I said, for bone only was 14% versus 7% for taking the dura and opening it up. As time has gone on with a change or philosophical approach of using the intraoperative ultrasound, trying to do the right operation for the right reason, and doing less tonsil manipulation, our redo rate now is down under 5%. It's interesting when we went back in these patients that need that second operation, almost all of them, 90% of them, have scarring at the outflow of the fourth ventricle. Even the patients that had the dura open, where it was open, exposed, and the scar tissue was taken down, those patients come back with that same problem. And then you can see in that slide on the bottom, that little white tube, that's a fourth ventricular stent, which to date has worked quite well. So to conclude, the literature will show you've got between an 80 and 90% success rate in reducing the size of the syrinx and or ameliorating the symptoms. Your morbidity, your complication rate runs between 3 and 15%. Usually it's single digits. Your reoperation rate runs about 10%. Obviously, this study's less and more, but that's a ballpark and a reasonable number. We saw at our own time frame, 77% of patients improved with respect to the syrinx or their symptoms. We had a 15% complication rate when you added everybody together, but only 4% for the bone only, 22% for the duroplasty. And I should comment that 22% is mostly CSF issues. It's a pseudomeningocele. God forbid the CSF's leaking, you got to put a shunt in. Most of the time it's manageable, but when a child comes back a week later with a big pseudomeningocele and they're not happy and mom and dad are not happy, I view that as a complication. It's readmission. And our reoperation rate was, when you add them all up, was 9% when you added the two groups together. But now, as I said, we're down to about 5%. So which is better, open versus closed? I think nowadays the data would support large syrinxes, certainly do better with an open operation. But for small to moderate sized syrinxes, for pain, a bone only, a non-aggressive operation works just as well. And the advantage, of course, is your complication rate is less, and your redo rate seems to be about the same. So we've seen roughly an 80% improvement if we look at the indications, pain, syrinx, or neurological findings. You'll see that by 2 years. And more importantly, and I probably went through this too quickly, at least up to 5 years it stays stable. We're not having kids falling apart. And in my 25 years at the hospital, I can think of 3 or 4 kids out of, as you see, all the kids that we've done that came back after 5 or 6 years with a recurrence of what they had. It's extremely rare. It seems to last. And again, we talked about this, open versus closed. If we have a whole cord syrinx now, we know that kid's going to need to have at least a bigger operation and so forth. We've reduced failures. And I said that's for a number of reasons. We try to minimize, I'm not saying it's wrong to do anything with the tonsils, but we try to minimize doing anything with the tonsils. It's just more scar tissue if you have to do it. We are tailoring the surgery what we think is a presumed etiology for why the tonsils are low. We're using intraoperative ultrasound. And then we know if it's a whole cord syrinx, it's not going to work otherwise. So in the end of the day, kids seem to do better than the adults. I think we've seen that, and maybe because it's a different etiology. It seems that you see it by up to really sooner than 2 years, but you see by 2 years and it remains stable. The hypermobile patients do just as well as the patients that don't have that flexibility and whatnot if you operate for the right reasons. If you don't, then everything, anything's possible. And again, we use duroplasty for the whole core syringes and obviously the redos, but otherwise we'll try to do bone only if we can do that. So do the right operation for the right reason. Etiology. If you come up with a presumable reason why the tonsils are low, that's what you need to go for. And often less is more. So I'll stop with that, and you got a few extra minutes for catching up.